Hello, my friends. Good evening, and welcome to yet another session of DocTutorials and RRM. And this is going to be the session where we are going to continue the rest of the recall session of INI SS Oncology 2025 November. I know it's late, and I had a high pack and it got over pretty late. And on the way, there was another meeting, and I had to come. But let's get on with it, my friends. And this is important. I believe that last minute revision helps. Now, every exam that I've ever attended, right from my school days till now, always I'll keep studying till the end. I know there are people who will say that don't study till the end, don't get yourself tense, sort of relax and do it slow, all that. But that is all true to some extent. But keep reading till the end without getting tense. That is the key of it. So when you do that, sometimes whatever you see at the end, a couple of questions are likely to come from that, and you will be able to answer. And I've had it in every exam that I've attended, not one, not two, every exam I've always found something that I was reading at the end has actually come up for the exam. So this session that we are having here today at 10:30 at night and probably will go on till around midnight. I know you got your exams tomorrow. So all the best and let's get on with it now. So one question, we finished till question 34 yesterday, which was on esophageal cancer. And mid-esophagus, the cancer management is going to be the typical cross-protocol chemoradiation with paclitaxel, carboplatin, and 41.4 gray of RT. So that is going to be the characteristic treatment. So then getting on to the next question. Colon cancer extending till the muscularis propria and lymph nodes are not there, then what is going to be the stage? Now, muscularis propria is an important determinant that is going to be your T2. So this is often asked as a question in examinations, the staging, and you don't need to remember all the staging systems of everything, but the common ways that you have to think about the important things that you need to remember. So T1 is submucosa and T2 is going to be your muscularis propria. T3 is the subserosa and or the pericolorectal tissues as we call it, and T4 is going to be where there is an actual invasion of the peritoneum or other organs, which will be there, visceral peritoneum or the other organs. So that is going to be your T4 disease. Now, T2 is going to be invasion of the muscularis propria, N0 status. Now, when we are talking about the nodes, this is something that commonly comes up. No regional lymph nodes are there, but the patient has got deposits which present in the subserosa or in the mesentery or anywhere along the area in the pericolorectal or the pericolic tissues. When you have that, then that is known as your N1C nodes. Now, all the other things are classical in terms of nodes, the number of nodes. So 1 to 3 nodes is going to be N1. N2 is going to be 4 or more, in which 4 to 6 and 7 or more will come. One node is considered to be N1A and 2 to 3 is going to be N1B. All of this have come, they've asked 2 to 3 nodes if they are present, what is going to be the stage? They have asked what it will be if 6 nodes are present, what is the stage? N1C is a question that often gets asked. They will say that there are deposits which are present, but no lymph nodal architecture is identified. What is the stage? So these are questions that keep coming up repeatedly. These are favorites with the examiners. In a similar vein, again, I will say that when you're talking about metastasis, remember in colon, there are few areas where you will have the subclassification of the metastasis. Melanoma is one, colon is another, ovary again, you will have it something similar. So M1ABC is there. So single. Basically, M1C is peritoneal metastasis. The way to remember is M1C is going to be peritoneal metastasis with or without other organ metastasis. So that is going to be M1C. So what about other organ metastasis? That is M1A and M1B. So single metastasis or organ is going to be M1A, and M1B is going to be 2 or more sites or organs. If it is identified, then that is known as your M1B. And in both A and B, you do not have peritoneal metastasis. M1C is your peritoneal metastasis. So this one comes as a T2 N0 stage. Now, stage 1 is going to be T1 and T2 N0. So this is a stage 1 colon cancer that we have here. Now, here the question is ovarian malignancy with serosal deposits more than 2 centimeters. What is the stage? Now, this question is sort of incomplete. It's not a complete question, I feel. I assume that the 2 centimeters that they are referring to is going to be something which is outside of the true pelvis. Serosal deposits, what we are having here is going to be outside of the true pelvis. So now when we look at the ovarian cancer as a whole, so T1, it's usually the FIGO stage that will be used. So don't look at the T1, T2 stage, etc. You look at the FIGO stage, stage 1A and 1B. So 1A, 1B, and 1C. So 1A is going to be confined to one ovary and no surface deposits are there. And again, capsule will be intact. So again, the same thing with 1B is going to be two ovaries Okay, limited to one or both ovaries with the capsules intact or the fallopian tubes, and there is no tumor on the surface. Now, what is T1C? Sorry, 1C. So 1C is going to be the one where you have the tumor involvement of the surface. So what happens? So you can have tumor which is present in with a surgical spill. So you can have a surgical spill which is going to be present. You can have the capsule ruptured. So surgical spill is the one that happens during surgery. You're taking out a tumor, it's a big one, large cystic masses, they sometimes tend to rupture. It's not easy always to take it out as a whole mass without any sort of rupture. So at times it will rupture. And if there is a surgical spill that happens, then that is going to be something where you will have a sort of like, scenario, but that is still okay. Now, the second thing is going to be your pre-operative or pre-surgery. Suppose there is already a spill. So you go in, you open the abdomen, immediately you see that the capsule has ruptured. So that is 1C2. And 1C3 is going to be the presence of ascites on cytology or in, peritoneal washing. So both of them, when it is present, then that is known as your 1C1, C2, and C3. Now the question here is with tumor extension beyond the ovaries onto the pelvis. Now pelvis, if it is involved, pelvic peritoneal involvement is generally considered to be stage 2. In that 2A is going to be implants on the uterus, fallopian tubes, or the opposite ovary. When it is there, then that is known as 2A. 2B is going to be implants in the other pelvic tissues like the pouch of Douglas, etc. Whenever you have. So pelvic peritoneal involvement will be 2B. 2A is going to be involvement of the uterus tubes, basically the female organs, the uterus tubes and ovaries. Any of these, if there is deposits, then you call it as 2A. Other than that, if there is, suppose there is a bladder deposit, there is a POD deposit, all that will be 2B. Now 3 is going to be the one where you will have the invasion, which is going to be here. So what do you have? 3A1, you have to remember in this 3A is going to be involvement of the tissues outside of the pelvis, in the sense that it can be involvement of the retroperitoneal nodes. So pelvic nodes come under 3A. 3A1 to be more specific is going to be pelvic and retroperitoneals. Both of them come under stage 3A. Remember this, my friends, because this is often asked. Nowhere else you will get it as 3A. All the other cases in the gynec malignancies, it will come as 3C. Here it is going to be 3A1. So 3A1 is going to be either pelvic nodes or parietic nodes. Again, usually pelvic nodes will have a lower stage and parietic nodes will have a higher stage. Here both pelvic and parietic nodes are considered together. So both of them are considered together. Either nodes are positive, then it is 3A1. It is the size. In that there is going to be a subdivision. The 3A1, again within parenthesis, 1 or 2 is there. So the size less than or equal to 10 millimeter and more than 10 millimeter, meaning 1 centimeter or more than 1 centimeter nodes are there. That is 1A1, sorry, 3A1 1 and 3A1 2. So that is going to be your nodal metastasis. So nodal metastasis in ovary generally have a better prognosis overall. So that is why they are considered under 3A1. Now what else is there? You have 3A2. What is this 3A2? So 3A2 is going to be the one where you will have disease which has gone outside the pelvis, and you're going to have your invasion of what you can say as microscopic deposits. I don't think I put up the staging here. I think it got cut when I was handling the thing. So basically, when you have involvement of the pelvic peritoneum, or sorry, outside of the pelvic peritoneum, that is the true abdominal cavity, microscopic disease is there. That is known as 3A2. So microscopic disease outside the true pelvis. That is why when you say you do an omental biopsy, or you do a paracolic biopsy, or you do a subdiaphragmatic resection, and those areas, if there is microscopic disease which is present, then that is known as 3A2. Now, visible disease less than or equal to 2 centimeters is there. Again, in any of these places, omentum, paracolic, or subdiaphragmatic, if the deposits are visible and they are less than 2 centimeters, that is known as 3B. And then finally, you have your 3C, which is going to be the size more than 2 centimeter, which is where you have it here. So ovarian malignancy with serous cell deposits more than 2 centimeter, if it is found, then usually peritoneal implants indicate that it is going to be 3C. So here it is a 3C disease. Remember, in every other condition, 3A will be, 3C will be nodes, but here 3 nodal disease in carcinoma of the ovary will be your 3A and not really 3C. And again, M1A and M1B are going to be there. So pleural effusion with positive cytology is considered to be one which is a special subtype. Generally, you will get on the right side. So right pleural effusion where there is a positive cytology which is going to be present, then that is known as your stage 4A disease. and the rest of it either parenchymal. Again, this is a question that will be asked: surface deposits versus parenchymal deposits in the liver and spleen. So surface deposits in the liver and spleen will come as stage 3. So that will generally come as either 3B or 3C depending on the size of the surface deposit. Whereas if there is a parenchymal liver metastasis in the liver or spleen or any other organ, if there is a surface deposit, then you will, kind of metastasis to extra-abdominal organs, inguinal nodes. That has come as a question. Inguinal nodal metastasis is not a local disease. It is considered to be a distant metastasis. And again, lymph nodes outside like supraclavicular nodes and transmural involvement of the intestine through and through. On the surface, if it is present, again, it is going to be stage 3, whereas transmural involvement through and through invasion, perforation of the bowel is there, that will come under your 4B disease. So these are some questions that have come up in carcinoma of the ovary time and again. Yeah, that has come up here. Sorry, it has come up in the next one. So as you can see, 3A2 is microscopic extrapelvic disease above the peritoneal reflection, above the pelvic brim. 3B is going to be macroscopic disease less than 2 centimeters. 3C is going to be macroscopic disease more than 2 centimeters. So all these three are going to be considered, and they have come as multiple questions in various examinations. Now, breast, again, the carcinoma staging of the breast is something that keeps coming again and again in various forms. It gets repeated. They have asked 3 questions last time. Usually you will find questions on staging that comes up repeatedly. So here again is no exception. So 3 centimeter lesion, no skin changes, level 1 and 2 matted axillary lymph nodes. What is the TNM stage that is mentioned here? So level 1 and 2, when you have the lymph nodes, which is matted node. So 3 centimeter, let's talk about the primary T2. This is a lesion which is more than 2 centimeters. Skin is not involved. So it is going to be a T2 and T2 lesion. Now, what about the nodal status here? Level 1 and 2, matted axillary nodes are present. So nodes that are matted, fixed or matted nodes will come under N2 disease. So it is a T2 N2 disease that you have here. So T2 N2 will come under stage 3A. So the T2 N2 will come under your stage 3A. That is the way you will classify it. And again, remember, my friends, this N staging can be asked in various ways. So fixed N1 is basically the mobile ipsilateral axillary nodes. Fixed ipsilateral nodes either to each other or to the surrounding structures in level 1 and 2 is considered to be your N2A disease. On the other hand, suppose you have your internal mammary nodes without axillary nodes, that is N2B. Okay, N2A, 2B is there. So N1 is mobile axillary nodes. N2 has got 2 stages, 2A and 2B. 2A is going to be fixed nodes. 2B is going to be your internal mammary without axillary nodes. Then N3 will have 3 different types, N3A, 3B and 3C. So what is 3A? 3A is going to be your infraclavicular nodes. 3A is considered to be a infraclavicular nodes which will come under the level 3 nodes. 3B is what? Presence of both internal mammary and axillary nodes together is known as your 3B, N3B, and N3C is of course the supraclavicular nodes. So all these have been asked at various stages, and of course interpectoral nodes are a common question. They come under the level 2 nodes. Interpectoral nodes will come under the level 2 nodes. It's not level 3, it will be the level 2 nodes as far as the interpectoral nodes are concerned. Right. Now this is a gentleman who has got, progressive dysphagia, heartburn with endoscopy showing resistance at the lower esophagus, barium with contrast hold up at 15 minutes. Next line of management is probably a manometry. This is not really looking like a malignancy. There is no ulcer or lesion which is seen. Endoscopy is already done. So next thing will be doing a manometry to do out a, sort of like lesion with an increased sphincter tone, which is going to be present there. Now, this was a question. I'm not sure whether it is worded right. Case of lytic bony lesions with renal lesions, it is mentioned. I'm not sure whether the renal lesions were mentioned in the questions because the rest of the questions are very clear. So multiple bony lytic lesions are present. For argument's sake, I am going to take it as this question is not having the renal lesions. Let us remove this because I saw one other person who had shared where the renal lesions were not discussed. So renal lesions were not there. So multiple bony lytic lesions with papillary thyroid carcinoma, what is going to be the management? Now remember, in a patient who has got papillary thyroid carcinoma, the first treatment in bony metastasis is going to be doing a total thyroidectomy. M1 disease, there are some indications for doing a total thyroidectomy. One of them is M1 disease. Whenever you have bony metastasis that are amenable to radioiodine therapy, then you will give total thyroidectomy as the first option. and then you have to plan for radioactive iodine ablation. So radioactive iodine therapy, high dose therapy will be given here. So the radioactive iodine ablation is not the term I would use. It's actually radioactive iodine therapy that I will use. So the first thing will be total thyroidectomy. Again, I'm not sure of what the exact options which were listed were, but I am assuming that you have to have it as what is the management of a patient with both of this. So it is first step is going to be a total thyroidectomy. Once you finish the total thyroidectomy, then you will plan for your radioactive iodine therapy. You will plan for therapy. So the patient will undergo surgery and then follow it by the radioactive iodine therapy to remove all, to treat all the viable distant metastasis. So once you have done that, the radioactive iodine therapy, then again you will do a scan and find out if there are residues. You can retreat them at around 3 to 6 months intervals. So that is the way it will be done. So multiple bony lytic lesions are there. Generally, you can go for treatment with radioactive iodine therapy. Now, remember, my friends, there is also an option. Suppose it is present, lytic lesions. It also depends on where is the lytic lesion. Suppose it's in a weight bearing area or something with pain, then radiation can also be an option. So it is all dependent on the exact way the question is thrown. So if you have got a lytic bony lesion, let's say there is a there is a lumbar lytic bony lesion with the patient having severe backache and impending fracture or something like that is there, then you may need to plan for SBRT. You may need to plan for radiation to address the lesion. If it doesn't resolve even with that, you may even have surgical resection of that and putting in a cage. So all these are various options. It depends on the way the question is going to be framed. But classically, papillary thyroid carcinoma with lytic bone lesions, the first treatment is going to be a total thyroidectomy. And then on, you will add on to radioactive iodine therapy. You will not do radioactive iodine ablation. It's called radioactive iodine therapy. Radioactive iodine ablation refers to the remnant ablation, which is going to be done here. Here it will be radioactive iodine therapy where you will give a much higher dose. Remnant ablation usually requires a dose of around 30 to 50 millicurie, whereas radioactive iodine therapy will involve a dose which is going to be much higher, usually in the dose of around 100 or 150 millicurie for a single dose, and then going up higher as the time goes along. So both of these will be required together. Right. So then you have got a patient who has got a lesion in the right upper lobe of the lung with a subcarinal node, which is 15 millimeter in diameter. So it is a 1.5 centimeter node. What are you going to do for a lesion in the right upper lobe? Now, there are a lot of things which are not very clear in this question. Again, the recall is variable. We all tend to recall the salient features of the question. We may not realize the importance of the other things. What is going to be the management? So my thing is just keep it simple. When you got a lesion here and you got a lymph node there, especially in the subcarinal area, which is easily amenable for doing a EBUS. So EBUS stands for endobronchial ultrasound, where you can just go in and subcarinal node is going to be there at the level of carina where it is bifurcating. So bang on, you can go and easily do a TBNA or transbronchial needle aspiration. So TBNA is it is called as. So TBNA will be the first step, because the decision on management or the type of treatment is going to be dependent on what you find as the node. So when you find a significant node, 1.5 centimeter node is significant, you will go for a transbronchial needle aspiration. That is going to be the first step you'll do, because if the node is positive, it will go to N2 disease and stage 3 disease, where you will treat the patient by initially chemotherapy or by definitive chemoradiation. Those two will be the options. It will be either chemotherapy, neoadjuvant followed by surgery, or it will be definitive chemoradiation, which will be the treatment option. So EBUS here, the treatment, the first choice will be, my choice will be EBUS and lymph node dissection. That said, you also have to remember that, there are multiple other things. So if you look at it, there is a peripherally placed lesion. Now they have just mentioned as a lung lesion. They have not mentioned the size. They have not given any other details here. It's a 5 centimeter lesion. It's a 2 centimeter lesion. There is a lot of difference. So if you look at the likelihood of having malignancy in a patient who has got a peripheral lesion, so there is a low likelihood of positivity. So in such patients, there is going to be a low likelihood of positivity. So suppose you have patients with a small node, if the lesion, if there is a peripheral tumor, especially in the outer third of lung, which is less than or equal to 3 centimeters, there is a low likelihood of positive mediastinal nodes when they are negative on the PET-CT or FDG PET-CT. So that you can avoid the mediastinal staging. So you don't need to actively chase. But in the presence of a node, whenever there is a node which is going to be present, then you will plan for your pre-therapy TBNA, that is EUS guided biopsy will be done. So negative mediastinal nodes versus positive mediastinal nodes is going to be an absolute must in considering this. So you will find out this, and if it is operable negative mediastinal nodes, then surgical resection. If it is positive mediastinal nodes, then you will go for neoadjuvant chemotherapy followed by surgery, or you will plan for definitive chemoradiation as the treatment options. So that is how it is. So in this particular patient, it is going to be EBUS and TBNA. So mediastinoscopy, TBNA, mediastinotomy, everything is there. But the simplest one is to go for your EBUS and your TBNA. TBNA stands for your transbronchial needle aspiration. That will be the most commonly used sort of like evaluation in this particular scenario. Right. This is not really related to this one. It's a general surgery question. I'm skipping this. Yeah, this is an interesting question. A patient with a hepatitis B with a tumor in the right lobe of the liver. So here you got a patient, hepatitis B, tumor in the right lobe, tumor thrombus, which is extending to the main portal vein. What is going to be the management? So hepatocellular carcinoma, viral markers positive, extension to the portal vein. There are multiple factors which are given here, each of which has got a important thing. Straight away, we can rule out a right hepatectomy. Whenever there is a main portal vein invasion, there is no role for a surgical resection directly going in. So can you do chemoembolization, radiofrequency ablation, or sorafenib? What is going to be your management? So these are the options that you are there. Resection can be straight away ruled out. So when you talk about it, in general, hepatic resection is indicated in a curative scenario. So basically, they have to be child's A. If they have very high, child's B or C are not amenable for a surgical resection. So you have to be cirrhosis child's A, and adequate liver function is there, and solitary mass without major vascular invasion. Very, very clear. There should be no major vascular invasion, and FLR, the future liver remnant, what is going to be there? So 20% without cirrhosis and 30 to 40% with class A cirrhosis. Now this number varies again, 20%. Some people say 30% is needed, but general dictum is, yeah, 20% in a patient who has got no cirrhosis, and about 50% is what is mentioned in a patient. Some patients will say 40 for post chemotherapy liver, and 50% for a patient with cirrhosis. So these are the things that are required to plan for a resection. Now, in following scenarios, hepatic resection is controversial. So when you have major vascular invasion, usually it is contraindicated. The major vascular invasion usually involves major vascular invasion of the hepatic artery and the portal vein. When it is going to be present, then it is considered to be inoperable, and patient is usually put on a palliative treatment. So here I would probably say TACE or embolization. So those are the two things that you will think about. So what are the options which is there when you cannot treat the patient with a curative intent? What are the palliative options? So then you have your ablation, you have arterial directed therapy. So TACE will come under the arterial directed therapy. TACE, TAR, TAE, all this comes under transarterial therapy. So transarterial embolization, transarterial chemoembolization, TAR, which is going to be with yttrium 90 microspheres, radio embolization, all these are going to be present. Now, in general, whenever you're talking about ablation, near major blood vessels, when the tumor is going to be there, you avoid it. Near major blood vessels, major bile ducts, diaphragm, etc. And when there is a portal vein invasion, you generally try and avoid it, right? So again, show that, sorafenib, yttrium 90 compared to sorafenib in advanced, this one, and radio embolization may be amenable in advanced, specifically with the segmental or lobar vein when there is a thrombus. Okay, so when there is a thrombus in, or a tumor which is extending to the segmental or lobar vein, you can consider yttrium 90, but main portal vein thrombosis is a contraindication. So whenever the patient has got any of this, so arterial directed therapies, systemic therapy may be appropriate following arterial directed therapy once if there is evidence of residual not amenable for local therapy. So here, if you look at it, what are the things which are available here for you? Here you have the options of right hepatectomy, which is ruled out. Chemoembolization is again ruled out because the main portal vein is involved. Radiofrequency ablation again will generally not be considered. Here, in my opinion, probably the best option is going to be your sorafenib for the treatment of this patient. It is going to be systemic therapy that will be given rather than the other forms of therapy. So it will be systemic therapy rather than the other forms of therapy that will be used for this particular patient. So this is again a favorite question, has come multiple times, and I have taken some special effort to give an update on this in our INI SS updates classes as well. So what we have here is a session on isolated limb perfusion, the diagram, the use of the drug, everything is there. We have to understand the difference between hyperthermic isolated limb perfusion and isolated limb infusion. Both of them are there. So commonly, where do you use it? Generally, it is used in your sarcomas and your melanomas, especially in melanoma. Agents used are usually melphalan and TNF. The two agents that are used are going to be melphalan and TNF. And what we generally tend to do, what is the difference between the two? Now, that is the first thing that I will talk to you about. So isolated limb perfusion, when you talk about it, it is an open surgical procedure, exposure of the vessels for catheter insertion. Let's say there is a lower limb thing or an upper limb thing. So you expose the axillary artery and the vein, or you do the femoral artery and the vein here, and then open surgical way, and then the catheters are inserted into the artery and the vein. So it is a sort of like longer duration thing. You need perfusionists, you need everybody, complex equipment are needed, and it's not possible in occlusive vascular disease. Technically challenging because you can't go on putting the patient under anesthesia and putting in a catheter and taking it out. That is going to be difficult, and systemic metastasis are normally a contraindication because of this. Whereas even in the presence of systemic metastasis, you can give your isolated limb infusion. And again, higher perfusion pressure. So here you have a membrane oxygenator, you will have an arterial line, you have a venous line, the tourniquet is right, and then you have a membrane oxygenator, the roller pump, heat exchanger, everything is there. So it is under pressure. So it's a hyperthermic isolated limb perfusion. So it is both higher temperature, more than 41 degrees is usually needed, and limb tissues will be oxygenated, and hyperthermia is maintained, usually requires your general anesthesia. So these are the things which are there in your isolated limb perfusion. On the other hand, in isolated limb infusion, it is a selling a catheter placement. So it is a percutaneous vascular catheter infusion. Time is much less. Perfusionist is usually not needed, and well tolerated by patients even who are elderly and frail. So these patients can also be used. And again, in patients with a occlusive vascular disease, repeat procedures can be done. Metastasis is not a contraindication. It's a low pressure system. It's just infusion. You don't sort of like give it under high pressure. What you do is you just put a tourniquet there, and then you keep circulating it, artery, vein, it keeps coming and going. And tissues, oxygenation is maintained there. Here there is no oxygenation, so it will be acidosis and hypoxia. And temperatures are lower. You reach a temperature of only around 40 degree, and this is usually possible with a regional anesthesia. These are the main difference between ILP and ILI. Crucial questions, my friend, because multiple times ILP or ILI based questions have come. So essentially, surgical, non-surgical procedure. ILP is a surgical procedure, complete isolation will be done, and there is a monitoring which is needed. So you'll have a scintillation detector, a monitor is needed. All that is supposed to be done in case of an isolated limb perfusion, and you have a heart lung machine and membrane oxygenator, heat exchanger, roller pump. So high equipment are needed. All this is things along with the thermometer, the thermostat, all this is needed, and thermocouples and probes. This is needed in a isolated limb perfusion, whereas in an isolated limb infusion, it is going to be a technically simple procedure, percutaneous insertion, advanced disease, it can be done. Patients who are not very good in physical condition, ECOG 2, 3 can also be tried. So perfusionist and other high-end procedures are not required. So this is the circuit which will be used, isolated limb infusion. This is the circuit which will be used. There is a tourniquet, there is a hot air blanket, and a heating element. That is all is going to be needed. Venous catheter, arterial catheter, and you have the drug which is going to be usually melphalan and TNF. So this was, I'm not sure what the exact question was, but these are the facts with regard to isolated limb perfusion and also with regard to isolated limb infusion. And I hope it is enough to make you answer the question. Right. So then there was another question that has come up on ICG. Now, ICG is something that keeps coming multiple times. ICG is something that keeps coming multiple times. ICG based questions are, you can expect 100% an ICG question. Now, question here is in a patient post chemo. So in a patient post chemo, what is going to be the thing? So post chemo, what is going to be that? So post chemo, which is the best mode of SLNB. Now, we all know about the three trials, the FNAC trial, the Sentina trial, and the MA17 trial. I mean, all these are trials that have been repeated. I mean, Akazog Z17 trial, 1017 trial. So these are all trials that have been done in post-neoadjuvant chemotherapy scenario. Now, SLNB used to be done only in the primary setting, but in the post-NACT scenario, there are some things that you need to follow. So what are they? You have to use a dual dye technique. It has to be a dual dye technique. At least 3 nodes have to be sampled. All suspicious nodes are removed. At least 3 nodes have to be sampled, and you plan for a targeted axillary dissection. What is this targeted axillary dissection? As we have explained in the class, suppose you identify a node which looks suspicious and is positive. At that time, you do a biopsy and you put a clip inside the node. The device can be, it can be a clip, it can be something called as a mag seed, which is a magnetic principle thing, or you can put plain simple India ink or some kind of long-standing dye which will be present. India ink is the usual dye which will be preferred. So all these, at the time when you go back, you go and give the patient. This is before starting the chemotherapy. So once the chemotherapy is done, 2 cycles, 3 cycles at least will be given. And at the end of it, you go back and you do the sentinel lymph node technique. At that time, you have to do a dual dye technique, usually a combination of blue dye and radio tracer. Nowadays, SLNB with ICG is being done, but commonly it is a, you know, blue dye and the radio tracer which will be done, and 3 nodes will be sampled. So at least 3 lymph nodes. Now, this is a question that is often asked: how many lymph nodes are minimum taken as far as your lymph nodes are concerned? So minimum 3 nodes are needed in a patient with a post NACT scenario. Otherwise, it is not needed. So in a post NACT scenario, you need to take up at least 3 nodes, and targeted axillary dissection is preferred because it helps to identify all the nodes which are initially positive as well, and those nodes have to be taken out. And that is the principle of doing your sort of like sentinel lymph node biopsy in a post NACT scenario. So in a post NACT scenario, you have to do all this, you have to take up all these, and you have to do that. Okay, correct. So the next thing, so there are some other aspects which are mentioned here, the dual technique. So this is the slide. So NACBP B32 was the trial for SLNB. ACOSOC Z11 is a trial where there is no need to complete the axillary dissection in case there are 1 to 2 nodes only that are positive, provided the patient is undergoing a BCS with whole breast RT. Okay, so that is the ACOSOC Z11 trial. So level 1, 2, 3, all that we know. So the 10% rule, we know that the agents which is used is technetium sulfur colloid most commonly, but also albumin, antimony, all these can be used. So ICG is the most preferred modality currently. 10% rule. So 10% of the 10-second ex vivo count. So you take the node out, whatever sentinel node is there in radioisotope technique, you take out the node. At 10 seconds, you measure the count. And if that count, whatever the values of the sentinel nodes, with more than 10% of the 10-second ex vivo count, all the nodes have to be removed. Okay, so that is the point. And post NACT, these are the trials: the Sentina trial, SNFNAC, and the ACOSOC 1071 trial. So dual technique has to be done. At least 3 lymph nodes have to be sampled and targeted dissection using the clip nodes or mag seed or India ink involved node. All these have to be removed. And these are questions have come multiple times. You can see the picture with fluorescent, the NIR image which is being showed here. This is the fluorescent dye image which is going to be shown here. This is your typical SLNB using your blue dye technique. So this is how the periareolar location is where it is commonly given. This is a blue stain lymph node which can be seen. This is a India ink which will be more blackish in color, that kind of thing. And again, you have the indocyanine green with the IR image that has come multiple times as a question. So all these questions have come multiple times, my friends. And remember, these it's an area of interest and can be answered easily in your exams as well. And this is of course the technetium 99M sulfur colloid. This is known as the neoprobe, one of the agents which is multiple devices which are available. This is a wireless transmitter. Some of them are wired, you have to connect it and you have to use it. Some of them are wireless. Most of them today come as wireless devices. So you measure this activity at the level of the tumor, and let's say the count comes as 1300. Anything more than 10 seconds, the ex vivo count is 100. So 100, 130 is the cutoff. So less than 130, till that level, you will keep searching for the nodes in the axilla. That is the 10% rule. Okay, so that is how you will go and assess, and you will take out the nodes in all these patients. Right now, DFSP, what should be the margins? Margins in DFSP are a controversial question. Now, there are options which are given like 2 or 3. Two accepted ones are either 2 centimeters or 3 centimeters. Now, as far as Sabiston is concerned, they have mentioned as at least 2 centimeters. Schwartz and Sabiston have mentioned is at least 2 centimeter margin is needed. So, in my book and also in practice, I do 2 centimeter margin as far as DFSP is concerned. There is no clear guidelines which are mentioned. 2 is there, 3 is there, everything is mentioned, but thing is at least 2 centimeters. So usually you'll go for a 2 centimeter margin. So we all know that DFSP is a 1722 translocation. That is a question that has been asked. So collagen with PDGF beta, so platelet radical growth factor beta, both of them are interposed together, and that is why they are responsive to imatinib. So commonly happens in the trunk or in the extremities, and it's a dermal tumor. It can be taken as a dermal soft tissue tumor, or it can be taken as a subdermal soft tissue sarcoma as well. Usually an indolent tumor, but with a tendency for local recurrence. High local recurrences happen, and so you do complete circumferential, peripheral, and deep margin assessment, which is known as the Mohs micrographic surgery. That is one technique. The Mohs micrographic surgery is one technique which will be done here, not just in melanoma or in BCC. Even in DFSP, you will do the Mohs micrographic surgery to get a clear margin. So in areas where there is a difficulty in achieving that margin, so those are areas. And what is the margin? The preferred margin is going to be 2 centimeters as far as your DFSP is concerned. Right. This is a straightforward sitter question. 3.5 mm depth melanoma. What is the margin of resection that has to be given? Clear answer is 2 centimeters. Remember, my friends, up to 1 millimeter, which is a thin melanoma, is 1 centimeter. This 0.5 will be sometimes mentioned in your melanoma in situ lesion. 1 mm or a thin melanoma is 1 centimeter. Anything more than a thin melanoma, the answer is going to be 2 centimeter. Okay, so the answer is going to be 2 centimeters. So in situ is 0.5. 1 mm is going to be 1 centimeter. Anything more than that, usually the answer should be 2 centimeters. 1 to 2 is again mentioned as, intermediate thickness. They will mention as 1 to 2 centimeters like that. But in general, overall, the answers are 0.5, 1 and 2. 0.5 for a melanoma in situ, 1 centimeter for a 1 millimeter depth, and more than that, whenever it is there, more than 1 millimeter depth is going to be there, then the option is always to go for 2 centimeter margin as far as your melanoma is going to be concerned. Right, this is an interesting question. Case of bilateral adnexal masses, C125 is 2000. What is the next management option that you will do for this particular patient? Now, interestingly, they have given NACT, they have given staging laparotomy, and they have given HIPEC. Here again, I will tell you that, it's not about the correct answer alone, it's about getting into the mindset of the examiner. Now, there are actually 2 correct answers to this question. You can go for NACT in a patient who has got a high C125 bilateral adnexal masses. You can go for NACT, but if it is a resectable mass, there is nothing wrong in doing a staging laparotomy as well. Though in today's world, many of us will tend to go for neoadjuvant chemotherapy because it can downstage the disease, give more time for a swag, improve the general condition of the patient. And in general, the cutoff is taken as 1000. When you have C125, which is more than 1000, generally there is a preference for going in for NACT, but I'll tell you there is no absolute value to say that beyond this you should not do. Ideally, you should do a diagnostic laparoscopy, look at it. If it is a resectable tumor, why not? You can still go ahead and do a primary cytoreduction. Primary cytoreduction followed by adjuvant chemotherapy is still applicable, meaning the staging laparotomy can still be done for this particular patient. Now, where does the role of HIPEC come in? HIPEC will come in interval debulking surgery or your interval cytoreduction. Only there the role of HIPEC will be there. And does that remain dependent on the CM25 value? Not really. Usually though, whenever we have a high peritoneal disease, you will have a high C125. It is a marker of peritoneal disease. C125 will be elevated in many conditions where there is a peritoneal dissemination. So it's a marker of peritoneal disease. But that said, that is not the only criteria. You will look at all the other things, and if there is extensive, basically stage 3 disease is going to be found, 3BC kind of thing, then you will plan for your HIPEC during the time of interval cytoreduction. Go for NACT, and then you will plan for CRS with HIPEC, that is cytoreductive surgery with your HIPEC. That is what you will be doing in this particular scenario, right? So Hirschsprung's disease, all that I'm not going in. Yeah, so lung cancer, which is not a gene. Now, in this particular scenario, actually, all of them are genes. AL, CROSS, MET, and EGFR. All of them are there. So among the thing, the least common is going to be MET. So I believe, though, that one of them mentioned that there was something which was mentioned as rat. One of the other people had sent me as saying that it is rat. If rat is mentioned, then that is the answer. If ret is mentioned, it is not so. If rat is mentioned, then yes, because you have AL, CROSS, BRAF, KRAS, everything is going to be there. All the things which are mentioned here are going to be present. MET is there, RET is there. There are almost like 20-30 different genes associated with various types of lung cancer and their treatments. NTRK is there. HER2 is being tried. So many things are there as far as lung cancer is concerned, as far as the genetics of lung cancer as in terms of your next generation sequencing is concerned. But that said, I believe the option which was mentioned in one other thing that I came across was it is about RAT. So if RAT is mentioned, definitely you can remember it is not RAT, it is only RET which is there. RAT is not there, then that will be the option. So now there is a question on assertion and reasoning. I don't know how the question was framed. So assertion proximal gastrectomy is not done in carcinoma stomach because there is a loss of propulsive action of the stomach. So you can do it. There is nothing like an absolute no in doing a proximal gastrectomy. It is an accepted procedure. So the assertion itself is wrong. It is not done in carcinoma stomach is wrong. So the reason whether it's right or wrong doesn't apply at all. So this question is a wrong assumption. The assertion is wrong, but the reasoning is correct. So why people don't prefer to do a proximal gastrectomy is because there is loss of propulsive action of the stomach. The proximal stomach is important for the propulsive action. So when you remove the proximal stomach and then you do an anastomosis, a tubing or some kind of thing you do and you bring it together, then there's a problem that there is no propulsive action. So stasis can happen, and that is the reason why your proximal gastrectomy is not preferred. So here the thing is assertion is wrong, but the reasoning is correct. So this is wrong, but the reason is correct. So this is the way I will deal with this. So again, assertion, peritoneal side lesions have a worse prognosis than liver side lesions in gallbladder cancer. Liver side lesions have more chance of liver metastasis. So here it's the opposite. This assertion is right, the reason is wrong. So the assertion is peritoneal lesions have a worse prognosis because they are going to be more favorable for developing peritoneal carcinomatosis. Very simple reason. When you have a lesion sitting on the peritoneal surface of the gallbladder, it is more likely to cause your peritoneal carcinomatosis, and so they generally tend to have a worse prognosis. Liver metastasis is less common in a in a liver side lesions. You will not have liver metastasis, you will have liver invasion. You will have actually an invasion. So that is why you will need to do a radical cholecystectomy here. Here you will plan for a radical cholecystectomy with your segment 4 and 5 resection. Segment 4B bar 5 resection will be done as far as your radical cholecystectomy is concerned. In a patient who has got a liver side lesion, you will have to plan for a radical cholecystectomy. That is the only indication which is there. So here the assertion is right, but the reasoning is wrong. Right. Image-based question. I'm not sure what this was. Yeah, this is a pretty straightforward question. Case of scrotal mass in a 28-year-old, first step in the management. Straight question. No need to have any kind of doubt. It's going to be a high inguinal orchidectomy. Now, in a patient young who has got a big scrotal mass. Now, remember, the mentioning here is a scrotal mass. That is why I'm not talking about biopsy. Now, biopsy is not directly done. You will plan for a sort of like a resection. There is a Chevasu maneuver which is available in a patient who has got a small screen detected sort of an ultrasound detected lesion where you're not sure whether it's malignancy or not. You plan for treatment like a malignancy. So there also you make an inguinal incision. You deliver the testis from the scrotum into the inguinal wound. And once it is done, you put a soft clamp at the deep ring and keep the vascularity intact, but you put a soft clamp to prevent the spread of the thing. In fact, you put the soft clamp first and then you deliver the testis inside the canal. Once it is inside the inguinal canal, then you cut open, you bivalve it. Suppose it's like a kidney, you cut it along the long axis of the kidney, along the hilum of the kidney kind of thing. So that is where you will bivalve the testis and then you will open it out and you will see what is the lesion. That lesion you will send it for biopsy. If it turns out to be malignant, then you do a high inguinal orchidectomy. On the other hand, if it is benign, then you can leave the patient alone. That is known as your Chevasu maneuver. But here it is mentioned as scrotal mass. So when there is a scrotal mass which is mentioned, yes, the option is going to be very clear. It's a high inguinal orchidectomy. Right. So question on CA cervix vaccine. I'm not sure what was mentioned here. So CA cervix vaccines are two. One is going to be a Gardasil, other one is going to be a Cervarix. Cervarix is usually no longer available. What you have here. So all of the cervical cancer vaccines will work against 16 and 18. So they are the most pathogenic vaccines that are pathogenic things which are going to be there. So they work against 16 and 18. So 16 and 18 are going to be always present. Now in your Gardasil 4, other than the 16 and 18, you also have the 6 and the 11. So 6 and 11 are also going to be there. And you have the non-valent vaccine, which is going to be Gardasil 9. So you have 6, 11, 16, 18, then you have 31, 33, then you have 45, then 54 and 57. So all these are the high risk HPV type. So you have in Gardasil 9, 7 high risk HPV, comma 6 and 11. Now the 6 and 11 will protect against your venereal warts, whereas in Gardasil 4 it's going to be only the 16 and the 18. Now what is the age at which you give? It is given from 9 to 15 years. It will be 2 doses at 6 months interval. 6 months interval will be there. And beyond 15, the cutoff 15 years and above, the cutoff is going to be 3 doses. You will give as 0, 2, 6 dose. So 0 month, 3 months, and then 2 months, and then 6 months. That is the dose that will be given. And till what age it can be given? The ages which I mentioned are 9 to 26 as far as Gardasil 4 is concerned. It can be extended from 9 to 45 years as well. Both of these are allowed. Can males be vaccinated? Males are also vaccinated. Males also are vaccinated, and it will prevent against your sexually transmitted diseases and your anal canal cancer, all your last lower anogenital squamous terminology. That is the technology, that is the terminology which is used more commonly now. So that lower anogenital tract cancers kind of thing. So that terminology, all the last malignancies like anal cancer, vulvar cancer, vaginal cancer, all of these can be protected against HPV, again protects against your OPC as well. Oropharyngeal cancer, again, when they are vaccinated, it can give some kind of protection against that. So can it be curative? Can a vaccine cure? Vaccines do not cure. So they are not used in the cure in a patient with a HPV infection. So it is before the establishment or before there is a cancer. But that said, some people use it as off-label indication when you have a HCIL kind of lesion, not HCIL, sorry. Whenever there is an LCIL kind of lesion which is there, so you can consider using it. But for your exams, just remember that it does not cure a HPV established infection. It can prevent the transmission. So you give it before establishment of an infection happens. So these are some facts about CA cervix vaccines. I'm not sure what was exactly asked. You can just remember this, and maybe you can answer the question, and that's about it. Okay, right. So now comes the next question. So which is going to be on sort of like, yeah. So next question is on inherited pancreatic cancer syndromes. I don't know again what was the exact question which was there. Lee from any HBOC, Bloom syndrome, ataxia telangiectasia, all of these were there which were mentioned sort of thing. And I'm not sure what exactly the question which was asked. The most common is your hereditary pancreatitis, which has got your highest risk of malignancy. BRCA2 is again something which will have a high risk of malignancy. So BRCA2 is again something which will have a high risk of malignancy. Hereditary pancreatitis, the risk is almost 60% to 80%. That kind of thing is going to be the risk. BRCA2 is again going to be somewhere in the range of 20%. So it is much less in your hereditary pancreatic cancer. So I'm not sure what exactly the question which was asked was. Without knowing that, I cannot really say the options. But remember that hereditary pancreatitis, the most common or the highest risk is going to be with your hereditary pancreatitis syndrome. Okay, hereditary pancreatitis syndrome has got the highest risk overall, right? So that is the only MCQ that I could think of from that, right? So then you have your question on the risk factors of pancreatic cancer. Again, no options were listed, so I'm not sure. Yeah, so this is a sort of like tricky question. 6 centimeters from the anal verge, rectal thickening is present, rectal cancer thickening is present. What is going to be the management? So remember, when a patient has got a lesion at 6 centimeters from the anal verge with the rectal thickening, the management is going to be your TNT protocol. Now, it is not clearly mentioned what is the stage, but assuming that this rectal thickening is going to be there, then we have to think that it is likely to be at least a T3 or more lesion. So when you have got a T3 or you have got a N plus disease, when it is clearly T1, okay, the management of rectal cancer is going to be when you have a T1 lesion, when you have a T1 lesion. 1 second. I think I can type it better as a text. Yeah. So when you have a T1 lesion, you plan for endoscopic resection. So endoscopic resection, or you can plan for your transanal excision. So these are the procedures which will be done in your T1 tumors. T2 is the one which will be usually managed by straight surgery. So you plan for upfront surgery as the option. T3 and or N plus disease is going to be there. Then currently the protocol is to go for TNT. And what do you mean by TNT? It's going to be your total neoadjuvant therapy protocol. So this involves either short course radiation or long course concurrent chemoradiation along with chemotherapy along with NACT. And then after that, you operate on the patient. Okay, so the sequence, whether you need to give radiation first or chemotherapy first, is again open to discussion. Usually it will be radiation first. Usually it will be radiation first because after giving radiation, there is a time frame that you need to wait. In that time, you can complete the NACT. So after completing NACT, then you operate on the patient and then you go for adjuvant chemotherapy. Then you plan for adjuvant chemotherapy. That is the way the thing will be done. And that is the management of your rectal cancer. Since it is mentioned here as anal verge tumor 6 centimeters from the anal verge, it's a mid-rectal growth. Again, there are lesions which are at the upper rectum. The upper rectum till T3, you can consider operating upfront. So upfront surgery can be done in a patient in upper rectal lesions till T3. So that is another thing that you may remember, because once I believe that question came, upper rectum T3 lesion, can you operate or do you always plan for neoadjuvant chemotherapy? That you can operate on the patient. There is no need to sort of like give the patient neoadjuvant chemotherapy or radiation in that scenario, right? Management, which is contraindicated if the lesion was near the hepatic vein. This was a very clear thing. The hepatic vein, whenever it is close to that, then you have the heat sink effect. So you have radio frequency ablation, which is based on frequencies of less than 30 megahertz. Usually it is going to be 0.5 megahertz. It's going to be 375 to 500 megahertz kilohertz range. That is going to be the radio frequency focus. And usually it will be like a single probe, or it can be like a bunch of probes which will be present. It can be like an umbrella, like the floral umbrella, like a flower pot kind of thing. So it can be like this. So multiple things can be there, or it can be a single straight needle kind of electrode which will be there with the area of thermal damage around it. And once it is inserted into the center of the lesion, usually under ultrasound guidance, but it can be done during surgery also. So you have the electrode which is coupled to an RF generator which will be there. Grounding pad is needed for this, and then applied to the thigh of the patient. So voltage and the electrode, active electrode is there, and then you have the reference grounding pad which will be there. So there is an alternating current and frictional heating. That is the whole principle of your radio frequency ablation. Temperatures more than 60 degrees are created, leading to immediate cell death. And you have to give a margin of 5 to 10 mm around it. So that is the zone of necrosis should extend to a margin of around 5 to 10 millimeter. So generally speaking, when there are vessels which are more than 3 millimeters in size, they may be undertreated because of the thermal or heat sink effect. So what do you mean with heat sink effect? Suppose there is a large vessel which is going there, and then you got a tumor which is sitting there right on the surface. You got it, and you're putting in the probe there. So what happens? This heat is going to go, but this area, the thermal thing is going to be carried out because of the flow of the large vessel. Anything more than 3 millimeters a large vessel, then the flow of the vessel, the flow of blood in the vessel here is going to take away that thermal energy, and because of this, the periphery of the lesion is likely to be cooler and is less likely to get the sort of like thermal damage, and that is known as the heat sink effect or the thermal sink effect which will be there. And generally speaking, tumors adjacent to vessels, you will avoid it, and here you will prefer to use a microwave ablation. So RF ablation cannot work in this scenario, but microwave ablation is found to be better in managing lesions which are close to the major vessels. And again, these are lesions which are used, these are things which are used for tumors usually less than 5 centimeter. In fact, the initial cutoff was only 3 centimeter for all these lesions. Later on, they expanded it and made it till 5 centimeters. You can go for RF ablation or your microwave ablation, or you can get it for SBRT as well. So stereotactic body radiation is also something that can be done for this kind of thing. So all these are possible in the management. And again, less than 3 tumors, less than 3 centimeters, if you have, that again can be treated by your local modes of therapy like microwave or radio frequency ablation. Right. So case of men 1 with hypercalcemia, how will you manage the parathyroid? So here it's very clear. So men 2, so let me use the sort of like the thing here. This is something which has come up commonly multiple times we use it. So men 1, it is going to be a 3.5 gland, or a subtotal as we call it. Okay, subtotal. That is the preferred modality because you prevent hypoparathyroidism. Hypopara is less likely. So the other option you can do is a total with transplant. With auto transplant is another option, but here there is higher chance of hypopara. Hypoparathyroidism is going to be higher, so you don't prefer a total, you prefer a 3.5 or a subtotal subtotal parathyroidectomy in such patients. Now, targeted, only the involved gland is removed, only the enlarged gland is going to be removed in your MEN2 associated. MEN2A is also associated, but here the incidence is only around 20 to 30% incidence of hyperparathyroidism. So because of this, you will do a targeted parathyroidectomy or selective parathyroidectomy is done as far as MEN2 is concerned, because that is where you will have only a lower incidence of hyperparathyroidism, and that is the reason you will not do that. Okay, right. Right. So, as I said, menin tumors of Prasad gene, autosomal dominant inheritance, primary hyperparathyroidism. In fact, it is the 100% penetrance by around 50 years of age, and equal incidence in males and females, rather than the sporadic form, which is more common in females. First clinical manifestation in 90%. So it will be the first manifestation of most of these patients, and all four parathyroids will be enlarged, and subtotal with the removal, less common, less hypercalcemia. Yeah. And remember, the thymus also needs to be removed. Why you need to remove the tumors? Because this is a tumor in men one where you have pit, pan, and part. That is pituitary, parathyroid, and pancreas. So pancreatic NETs are common. In the same way, thymic NETs can also happen. NETs of thymus which can happen, and they are pretty lethal. And that is the reason you will always do removal of the thymus as well. And the remnant which has to be left behind is a 50 milligram remnant. So the remnant is that is roughly the size of the normal parathyroid. 30 to 50 milligram will be left, and it should be marked with a hemoclip in case you need to. Hemoclip is one, or you can put a non-absorbable suture as well. You put a proline stitch there and you leave it, or you mark it with a hemoclip, liga clip, or something like that. You leave it so that in case it later on develops into symptomatic parathyroid, then you will go back and you will remove that parathyroid as well in case the the hyperparathyroidism symptoms happen. Okay, so these are some questions which are not really significant. Post lobectomy of the lung, usually it will be the pulmonary artery or the bronchial artery. These are the ones that will be commonly involved. So there is no clear data on that. So on the post-op day 1, whenever you have it, what is going to be the most common results? On post-op day 1, actually it will be the intercostal arteries which can be happen. All three are listed. I couldn't really find the answer to this question. Most commonly on the day of surgery, it will be the pulmonary artery that will tend to happen. It can be intercostal or the bronchial in the post-operative day 1. So these are questions that were there, and that finishes our discussions. And hope, my friends, this was a useful session for all of you, and all the best. Attend the exam well and do well. Sorry, I got delayed, and there was a long case and pretty tough and all that. So all the best, my friends. I'm sure you will all do well, and let's get back, and please share the questions as well. Once you're done, please share the questions in the group. We have the INSS group, so please share the questions so that we can have further such sessions for people who will follow you. Only if we get the questions, then we can give you the answers. So thank you again for joining me today, and I hope the session was useful to you. Thank you.